Awesome, thanks, John. So these are my disclosures, none relevant for this topic. Go over the objectives. So we're going to briefly talk about cervicothoracic anatomy, the pathology leading to these type of deformities, operative and non-operative management, optimization, and then really focus on the parameters and the three classification systems that are most commonly used. So bony anatomy, main thing I would say here is just the transition between the C7 and T1, going to where you have your costotransverse joints and the costovertebral joints. Biggest thing for us is muscle and ligamentous attachments. So you have your nuchal ligament that goes down to C7, and then starting at C7 to T1, you have your supraspinal ligament. And so you talk to Dan Rue in dissection. This is the most key point in order to keep that tether distally here, where your traps, your rhomboids attach, and then your spinalis and your multifidus. Ligaments, like we talked about, ligamentous attachments, these just show that a little bit clearer here, primarily at that cervicothoracic junction. This is where you can get into trouble with iatrogenic deformities if you're doing too big of a dissection, especially at the end of your construct. So what are the signs and symptoms of cervical deformity? So inability to maintain horizontal gaze, inability to stand up straight without compensatory maneuvers such as bending your knees, head tilt in the sagittal coronal plane, neck and shoulder pain worsened with upright posture, ambulation, neurologic compromise, cervical myelopathy. Main thing here is the inability to keep your head over top of your pelvis. And what ends up happening is you can't maintain a good horizontal gaze, and your muscle expenditure gets increased and causes pain and a progressive deformity as the day goes on. Why does this matter? So based off of the research, that cervical adult deformity is on the same kind of line as people who are blind, emphysema, renal failure, and even breast cancer. What are the etiologies of a cervical deformity? So we have your degenerative, traumatic, iatrogenic, neuromuscular, infectious, and congenital. I'd say in our practice, the top 5 are the ones that we see most commonly. In terms of determining what is the cause. So you've got to do an appropriate workup, and it all starts with an appropriate history and physical. So seeing, what is the root? Are they an IV drug user? Have they had previous laminectomy before? Have they had a cervical intramedullary tumor that's been resected? What is that source? And then talking about the physical exam. So putting your hands on the patient, finding if they do have any objective signs of cervical myelopathy, have them walk, see what compensatory measures that they take into account when they're walking, when they're standing. Other things to do is to test range of motion, and then also lay them down. See if they do have a cervical deformity, is it fixed? If they lay down, does it correct itself? In all of this, getting dynamic cervical x-rays and standing scoliosis films is paramount. So this is what's going to allow you to look at all of the parameters and see exactly where, if they do have a deformity, where it's coming from. During the workup, CT, MRI, especially if they have neurologic compromise. If there is any concern for a neuromuscular etiology, whether myasthenia gravis or Parkinson's disease, get a neurology evaluation prior to proceeding with any sort of deformity correction. And then obviously if something looks like it's infected, get the appropriate lab workup. So the deformity parameters can be broken down into 5 kind of generalized categories. So you have your gaze and cervical curvature, your global cervical alignment, occipital-cervical junction, cervicothoracic junction, and then your overall alignment of your cervical-pelvic alignment. So we'll start with the first one, gaze and cervical curvature. Some of the most common ones that we see, cervical lordosis, measured from the inferior end plate of C2 and C7. Literature varies in terms of what a normal cervical lordosis is. You'll see it go anywhere from 13 up to 23, depending on what paper you look at. Chin-brow vertical angle, and this is to assess their gaze, which is also with slope line of sight. If you have a chin-brow vertical angle of plus or minus 10 degrees, that's whenever it becomes significant. So you measure from their forehead down to their chin and then a vertical line. Same thing for slope line of sight, except this utilizes the horizontal gaze. So you have a fixed horizontal line and then drawing a line from the external auditory meatus to the inferior portion of the orbit. Global cervical alignment, main one that we're using is cervical sagittal vertical axis, so your cervical SVA. You're measuring that from the posterior aspect of C7 going to the dens there, and you want that less than 4 centimeters. You also can look at your cranial tilt and your cranial offset, just another 2 measurements in order to see where your deformity is coming from. If your cranial offset is significantly higher than your cervical sagittal vertical axis, that can tell you that you need to go up higher than C2. Occipital cervical junction, so your CO to C2 angle, C1-2 angle, and then your C2 slope. Your C0, which is your base of your foramen magnum to the inferior end plate of C2, should be about 25 degrees. Looking at your C2 slope, this is the one I would say I most commonly use, and especially it's after we've performed surgery, and you want to keep this less than 20 degrees. Anything greater than 20 degrees, you can see an adjacent segment failure. Cervicothoracic junction. So most common one that we see, T1 slope, measuring your T1 to cervical lordosis, which should be around 16. And then your thoracic inlet angle, which is your neck tilt and your T1 slope. So this is similar to your pelvic incidence in the cervicothoracic parameters. What you want to look at with your T1 slope is if you have a T1 slope that's greater than 32 degrees, what that tells you is that you have a high likelihood of a thoracolumbar deformity. Your thoracic kyphosis is typically more than 50 degrees, and your TPA, your T1 pelvic angle, is going to be greater than 20 degrees, which we'll talk about here. Maybe. All right. So the general big alignments here, so your C2 spinal pelvic inclination, your T1 spinal pelvic inclination, these are what are really going to drive determining where your deformity is located. So this is a line that goes from the middle of C2 or middle of T1 down to your femoral heads in a vertical line. If you have a very high C2 spinal pelvic inclination, but a normal T1, that tells you have a cervical deformity. Opposite's true if you have a T1 that's high and a C2 that's low. You have a thoracic deformity, and both are high, you have a cervicothoracic deformity. The one that I typically use the most is a T1 pelvic angle. This is more for thoracolumbar deformity, but anything that's less than 14 degrees for a TPA tells you that you've done a good job in terms of your correction for a thoracolumbar deformity. These are just demonstrations here. So there was a paper that came out in terms of the reliability of measuring these angles and which ones we should use. And you can see on the table here the most reliable and the least reliable. It was funny to me that one of the least reliable ones was our T1 cervical lordosis. We use that very commonly to see what our mismatch is. But where does all this play? How can we describe it? You know, all of these, you can sit there and you can measure all these angles for 20 minutes, but what does it mean? How do we communicate it to other physicians? So there's 2 classification systems that are based off of static radiographs, and then one that is based off of dynamic radiographs. First one was the Ames classification system. This is based off of the apex of your deformity. So whether it's cervical, cervicothoracic, thoracic, or sacral, or the junction. Then you have modifiers, so looking at what your SVA is, your horizontal gaze, your cervical lordosis mismatch, and then whether or not they have myelopathy, and then utilizing the Schwab classification. So this can be pretty in-depth whenever you're trying to describe this to another physician. There are more simpler classification systems such as the Kohler with the European Cervical Spine Research Society. They came out with 4 different classifications. I would kind of focus at number 1 and number 3 here. So number 1 is a focal cervical kyphotic deformity, and then number 3 is a cervicothoracic deformity, both with the third one being with global imbalance. This just really allows you to describe these types of deformity. Hanjo Kim then came in with a classification system that not only defined these deformities into 3 groups, but also gave us an idea of how to treat it. So group 1 is a flattened neck without compensation. So this is people with a low T1 slope, but with a high cervical kyphosis. Group 2 is a focal deformity, so very focal kyphosis, usually at 2 levels with a normal T1 slope, a low T1 slope. And then group 3, you have a very large T1 slope with a compensatory cervical hyperlordosis, and this tells you that it's a cervicothoracic deformity. So this is one of the tables that he had, just demonstrating, in the lateral alignment and then in extension, so you can see different degrees of correction. But what this tells you is what you need to do and where you need to stop. So those flat necks, these are typically ones where you are instrumenting either doing an anterior and posterior approach or just going posterior and then stopping at that high thoracic stopping point, T1, T2, because you have a low T1 slope. If you have a focal kyphosis, this is almost always done through a combined anterior-posterior approach, whether you're doing multi-level anterior cervical discectomies or doing a corpectomy, and then backing it up posterior with osteotomies in order to correct this. But you can typically do this isolated within the cervical spine, depending on where the kyphosis is located. And then the third one being cervicothoracic. These are the ones where you're going posterior, you're doing long constructs, C2 to T8, T10, and you need that fusion link distally to prevent a distal junctional kyphosis and failure. So ultimately, the surgical treatment considerations, neurologic compromise, severity of the deformity, any progression of the deformity, and you got to take into account their comorbidities. In summary, this is a very debilitating pathology. You need to perform an appropriate workup to uncover the etiology of this deformity. Optimizing them preoperatively is paramount, especially in the elderly population and those who do not have signs of cervical myelopathy. Using these spinal parameters can help you localize the deformity. I think finding which ones work best for you and utilizing them in your practice is important. And then using a classification system in order to help communicate among surgeons and help us to determine a surgical plan.